All right, traction is one of those subjects where there's a little bit of theory behind it and a lot of practice. So it's, I've definitely worked in clinics where there was a lot of traction being done and there was a spinal, like 2 or 3 spinal traction setups on all the time, and we did traction on a lot of people. The clinic I work in now, we do it occasionally, fairly frequently. Sometimes we're using a regular traction table, which we'll practice on in lab. Sometimes we're using home traction units, which we'll also practice with in lab. And sometimes we're teaching people to do self-traction techniques or positional traction techniques. So really, traction is mechanical, manual, or gravitational force to attempt to actually pull apart the joint surfaces or lengthen the surrounding soft tissue. So it's a very physical modality. So we're going to talk in this lecture about the effects of spinal traction, indications, of course, contraindications, precautions, and adverse effects, how you do it, and how you document it. So pretty straightforward. And I have a lot of pictures. There are a lot of slides in this PowerPoint, but a lot of them are pictures of equipment, and we will see those in the lab as well. And then certainly when you go in the clinic, you'll see different setups in the clinic. So the effects of spinal traction, this just an overview: joint distraction, so pulling the joint surfaces apart, reduction of disc protrusion, soft tissue stretching, muscle relaxation, and joint mobilization. So lots of different effects, a very physical process. So just a review of the spinal anatomy. In between the vertebral bodies, we have the discs. The intervertebral foramen are also in between the vertebral bodies. We have spinal nerves coming out through those foramina, and the facet joints. So traction affects all of these. It gaps the facet joints. It pulls up on the disc. If you remember the anatomy of the intervertebral disc, we have the gel inner part, the nucleus pulposus, and the fibrous outer part, the annulus fibrosus. So we can affect where the gel sits in the middle with traction. So joint distraction, it is the separation of two articular surfaces perpendicular to the plane of the articulation. So it's basically you're just pulling those two articular surfaces apart. It reduces joint compression in the spine and widens the intervertebral foramina. So if you have pressure on articular surfaces, interarticular structures, or spinal nerve roots, joint distraction using any type of traction can reduce pressure on those things. So a lot of times by reducing the pressure, you also reduce the pain and associated symptoms. So joint distraction requires enough force in order to do it. So when we're talking about lumbar joints, we're talking about 50% of body weight. So if you weigh 150 pounds, you want to get up to 75 pounds of traction force in order to distract the lumbar joints. Cervical joints, they're smaller, obviously, and we're talking about 7% of body weight for cervical joints. So much less. Traction units have a nice little safety setting. If you put it on the cervical setting, you can't go over a certain pressure, certain mechanical force. If you set it on lumbar, you can go a little bit higher. So spinal nerve root compression can be caused by a disc protrusion, disc degeneration. It can be caused by that spondylolisthesis or the forward slippage of the vertebra. We'll talk a lot more about this next summer in your therapeutic exercise and orthopedics class. But there are a lot of causes of spinal nerve root compression. So traction can help reduce disc protrusion. So it actually can reposition the disc material back to the center from suction due to increased intradiscal pressure. So again, it requires sufficient force. So you need 60 to 120 pounds, or 30 to 60% of body weight. So in order to reduce disc protrusion, you need quite a lot of force. So here's our little picture. We've got the disc protruding and it's pressing on the spinal nerve. We are pulling traction longitudinally along the spine, and it sucks the nucleus pulposus back into the center. So it repositions that nucleus pulposus. The traction pressure actually tenses the posterior longitudinal ligament at the posterior disc and pushes the disc material anteriorly towards the central position. So the 60 to 120 pounds, or 22 to 55 kilograms, comes from studies, reporting results. Usually, the studies are out there really show no improvement when applied to large discal herniations that fill the spinal canal or protrusions of calcified disc, and that makes sense, right? If you can't, if it's calcified, you can't move it, and if it's too big, you're not going to have enough effect to decompress the pressure on that spinal nerve. So improved symptoms can also be due to concurrent increased neural foramina size, changes in soft tissue or nerve tension, and modification of muscle tone. So there are lots of effects that traction can have on pain, and some of them have to do with reduction of disc protrusion. The soft tissue effects, soft tissue stretching in the area may contribute to spinal joint distraction and a reduction of disc protrusion or increased spinal range of motion. Frequently, to get these soft tissue effects, we're going to be combining traction with other modalities like ultrasound or superficial heat or soft tissue mobilization. Not to say that we're going to be doing them at the same time, but maybe we're going to do ultrasound and soft tissue followed by traction to get the soft tissue stretching and the muscle relaxation effects. So usually the muscle relaxation is due to reduced pressure on pain-sensitive structures or gating by intermittent traction. So you influence those tension-sensitive structures in the muscle spindles and Golgi tendon organs to reduce muscle tension and increase muscle relaxation. So it makes sense. We have those soft tissue effects as well. So joint mobilization by high traction force or repetitive intermittent traction stretches soft tissues using that high force traction. The oscillatory motion of intermittent traction can stimulate the joint surfaces. It stimulates mechanoreceptors and can produce a gating effect. That can also happen when you do peripheral joint mobilizations, which you will learn in your manual therapy class next fall. That oscillation can stimulate those mechanoreceptors to produce a gating effect. When you're using mechanical traction, it's very difficult to localize the mobilization to a single joint. So you're mobilizing many of the joints at once. You can use manual joint mobilization techniques on the spine and on other areas to get a more localized effect. So clinical indications for spinal traction, disc bulge or herniation, of course not too big a one, we talked about that, nerve root impingement, joint hypomobility, subacute joint inflammation, of course we probably don't want to use it with acute inflammation, and paraspinal muscle spasm. So we'll talk about each of those. So with disc bulge or herniation, lumbar traction can improve symptoms and clinical findings and decrease the size of herniated disc in patients with lumbar disc herniation. It's best applied soon after injury when the protrusion is the soft nuclear disc material, because that's more likely to respond than anything else. And it prevents further herniation, which is nice. So in combination with other techniques for reducing stresses on the spine, like posture, body mechanics, lumbar stabilization exercise, patient education, those things are all really important for preventing recurrence of the disc herniation. So for nerve root impingement, it can be associated with a disc bulge, a ligament issue where the ligament is encroaching on the nerve, stenosis, foraminal stenosis, osteophytes due to degenerative processes, nerve root swelling, or spondylolisthesis where the a vertebra is shifted anteriorly on the one below it. It possibly temporarily increases the size of the neural foramen, reducing pressure on the spinal nerve root. It tends to work best shortly after onset on people whose symptoms increase with spinal loading and decrease with spinal unloading, and radiating symptoms aren't improved by trunk exercises. So some people will get effects, and I always say to people when I'm doing traction for the first time, either it's going to help or it's not. It's not usually a mystery. People who get good relief from traction, usually the first time they say, oh, yes, I noticed a difference. If it's, oh no, I didn't notice a difference, maybe you might try it one more time with some different settings, but if they're not noticing any difference, then you probably need to go to a different treatment. If the patient has worse symptoms with traction, then again, you probably want to go to a different treatment. Joint hypomobility. Traction can glide and distract the spinal facet joints to increase mobility. The effect is non-specific, meaning you're not affecting an individual joint, you're affecting multiple joints. And increased flexion localizes force to upper and lower thoracic. So, so if you apply the traction in flexion, you get into the upper and lower thoracic. If you apply it in neutral or extension, it localizes the force to the lower lumbar area. So your positioning has a lot to do with where you want to localize the force. However, it's still non-specific, affecting multiple joints. So with subacute joint inflammation, the force of the traction reduces pressure on inflamed joint surfaces. So small movements might have a gating effect on the pain and maintain normal fluid exchange in the joints. So a lot of times you're doing intermittent small oscillatory movements to help reduce edema, promoting that fluid exchange. Paraspinal muscle spasm, it's usually reduction of the spasm pain cycle via the stretch response of tension regulators in the muscle. Reducing the underlying cause of pain also reduces the spasm pain cycle, like if you have a herniation or nerve root impingement. Usually you're doing static, either low load intermittent or higher load traction to reduce the underlying cause of the pain. So this is a mechanical traction unit similar to what we have in the lab and what you'll see in a lot of therapy settings. Of course, the thing that's missing in this picture is the table that the patient's going to lie on. I have some pictures of those. So here, hey, here's the table. And this has its little traction unit too. So a lot of traction tables are split, so you can get movement. As you apply the traction force, the table moves to localize it to the area of the body that you want it to be in. So here's a patient on mechanical lumbar traction in supine. In flexion with the knees supported, and there we're trying to localize it to the lower lumbar area. Prone lumbar traction or slight extension is another way to apply the lumbar traction. The traction belts, you'll see both of these. The new style basically has Velcro, and the old style has buckles. No, I almost feel like I can, maybe just because I'm old school, but I can get it a little tight. I get a little tighter with the buckles, but you will try both. see how they work. So the lumbar traction, one belt goes under your arms, over your ribs basically, and the other one goes over your hips, and so you're pulling between the two traction belts. Mechanical cervical traction, there's a unit that supports your neck and kind of goes underneath your mastoid processes, and the traction device attaches to it. This is what the halter looks like, and we'll practice with those in lab. Home traction units, really similar. The one on the left here is cervical, the one on the right is lumbar. They use a little air pump to provide the traction. They're actually really easy to use and very effective. I've seen some good effects with people with home traction units. There's also this over-the-door traction unit. The main appeal to these is they're extremely cheap. So these traction units are a little more expensive, but the over-the-door traction unit is not always easy to get the right placement. It's difficult for people to relax in that upright position. It's definitely a choice that can be made. Self and positional traction is where you use your body weight to exert distractive forces of the spine. So it can be used for lumbar, but not really cervical. You don't want people hanging by their necks or anything. But it's good for situations where low forces are required. So in the first picture there, the guy is raising up from the chair. He's using self-traction for the lumbar spine. You can do this in the pool too, floating on a noodle and letting your legs dangle, which is kind of nice. In the picture on the right, we're using positional traction to stretch and distract the left lumbar area. So if we're trying to gap the facet joints on the left, this might be the way that we're doing it. And this is a nice way to be a little more specific with your traction forces. Of course, we're going to be low force. It's going to be a low force type of traction. Here's another way you can apply self-traction to unweight your spine. Just you're in the kitchen and you're in the corner there, and support yourself on your arms and let your body dangle. Sometimes that can be really a nice relief on your spine. So the nice thing about the positional traction is you can gap a specific level, and it uses three-dimensional gapping. So you get in a combination of flexion, rotation, and side bending that's going to gap the joint that you want. And so a lot of times positional traction can be effective for the right things. There's also, here's self-traction on an overhead bar. You get a little more thoracic effect on that. And you can apply traction manually, where the therapist positions the desired spinal level for gapping and then creates a manual distraction force. So you can use your hands, you can use mobilization belts, which we'll try in our manual therapy class. You can also use the lumbar traction belt from the mechanical traction unit, put the belt on the person, and then you provide the distraction force doing that. That actually works really well. Sometimes if you're trying to determine whether you want to do a trial of mechanical traction, doing manual traction first and seeing how they respond to it is a good way to decide if you're going to, if it's going to be an effective technique for them. So manual cervical traction, here it shows supine and upright, doing some traction on some people there. So this is a table from the book with recommended parameters for the application of spinal traction. And I'm not going to read through all this for you, but I'm going to have you look at it. Obviously, you start out lower to begin with, and then you might increase. We will talk about positioning in lab, so you get the proper positioning. Static or intermittent. Intermittent is generally more comfortable for the patient. Static requires less weight, and you're often using it in the acute phase. Usually you start out with maybe 5 to 10 minutes to avoid a lot of muscle soreness, and you gradually increase to 20 or 30 minutes. There's no established data on the frequency of treatments, but generally more frequent in acute situations, like if you have radicular symptoms. A lot of times we're having to educate people on, well, how do you know if it's helping? One of the ways you know is if you get centralization of symptoms. So you have some radiculopathy, pain going down your left leg, for example. And so you started out, it went all the way to your foot. After the first time of traction, it only went to your hip. Well, that's an improvement because the pain is centralizing. So they might still have the pain, but it's not going as far peripherally. So contraindications, of course, we always want to start with a low force and monitor for adverse effect. If motion is contraindicated, we don't want to do traction either. If you have acute injury or inflammation, you might make it worse. Joint hypermobility or instability, obviously not good. Peripheralization of symptoms of traction. So I was saying, if the symptoms centralize, you know it's helping. If they peripheralize, it's making them worse. So that's a contraindication. Uncontrolled hypertension, because you just don't want to put extra pressure on their system. Precautions, structural diseases or conditions affecting the spine. So osteoporosis, it's a structural disease. However, you might have someone where it works for them, it's the right thing. If the belt pressure is an issue, like if somebody has an incision scar, or if they're pregnant, might not be their thing. A displaced annular fragment, because you don't know where that thing's going to go. A medial disc protrusion, because you're probably not going to get the effects that you want. When severe pain fully resolves with traction, you're like, uh-oh, something's going on here. So you definitely have a nerve impingement or something like that. And then when you take them off the traction, the pain's probably going to come back. So that's something that probably needs a referral back to their physician. Claustrophobia, the belts have to be pretty tight, and some people with claustrophobia find it unbearable to be sort of tied down like that. If a person can't get into a prone or supine position, you're probably not going to be doing mechanical traction with them. If they're disoriented, this is not a treatment for someone who's disoriented. It's not going to help them reorient, that's for sure. For cervical traction, people with TMJ problems or dentures, it can exacerbate TMJ problems, and it can actually do damage to dentures, so you want to be careful with that. Adverse effects, excessive force may increase symptoms. You might have a rebounding increase in pain. So you want to start low and increase slowly. You might have lumbar radicular discomfort after cervical traction. So definitely check in with your patient really closely. Put it in your plan for the next time to check in with them, and tell them ahead of time, hey, I want you to take note of what happens later on tonight after you've had the traction, and tell me next time. Then they'll be prepared to notice and to report back to you. So, of course, we always evaluate the patient first. Our PT does it. They determine that it's appropriate and safe. They select the appropriate form of traction. We explain the procedure and the rationale to the patient. We apply the traction. And then when the treatment is complete, you assess the outcome and you document. And you say whether it's static, intermittent, how much force, what type of apparatus you used, the length of time, any positioning notes, and you're going to document the reaction to the treatment. So, wow, this slide really got messed up. Let's just pass and we'll come back to this. So, documentation, type of traction, where you applied it, patient position, type of halter if that's relevant, the maximum force, or your force settings, treatment duration, response to intervention. And with intermittent traction, you're going to say hold time and relax time, or on-off times. So you might have a little bit of force during relax time. So usually you say time on and off and force on and off. So you'll say like 30 seconds on, 10 seconds off, 20 pounds, 5 pounds, something like that. So you're going to document that. Okay, so it's going to be fun in lab to practice with the traction, see how it feels. see how easy or difficult it is to position people, and hopefully you guys will get a lot out of it.